Thanks, Jay.
Thank you, Mr. President. Yeah, Travis Scott, that's pretty awesome. I need to be there, right? Again, excited, David, that you could be here with us, as well as President Hartzell. Really appreciate that. So we're here.
We're here.
You've a year and a half or so into the new gig, and you're still here. So, really excited. Excited to have you here today. I thought it may be a good idea, maybe if you could just share a little bit about your prior experience before coming to Dell Med at the Mayo Clinic. Mm-hmm. Talk a little bit about how that experience, in some ways, if it's even possible, prepare you mm-hmm. for where you are today. And in particular, right, some of the things you're thinking about in terms of the future of Dell Med, the future of UT Health, and its intersections with AI and the future of healthcare.
Yeah, no, thank you. So a year and a half in, and I reflect on what set this path in motion. I'd spent 27 years of my career at the Mayo Clinic. Actually, even longer. I started doing research there when I was 19, actually in college, and then would continue. And this opportunity here was just this unique intersection of bringing this amazing university intersecting with the changes happening in Austin, the growth in the city, and this new medical school and the chance to really have an impact on healthcare in a meaningful way within this community. And when my roles at Mayo, I was the chair of neurology, I was the dean of clinical translational research, and I was a member of the board of governors with a particular role on overseeing the digital solution strategy for the Mayo Clinic, a member of a group there. And what that afforded me over particularly the last 5 years before coming here, a relentless focus on the disruptions happening in healthcare and being prepared for it and never complacent, no matter how excellent your care delivery was and is at Mayo. And with that, just a recognition that the situation was changing in healthcare. We were seeing, of course, we're all seeing that where people get their care, their expectations of their care, the desire for more personalized care, the speed within which data and technology was accelerating. And here we were really focused on how are we going to prepare for that. And in that role, Mayo began to really focus in the last 4 years on, one, digitizing its data, creating a data platform, recognizing that the future was accelerating. AI was already sort of front and center in the mission to think about how to use what we call now traditional AI. And in that regard, as a chair of neurology, focused on standing up a neurology AI program, recognizing that I could just jump right away into funding a lot of projects, but you needed a team, a multidisciplinary team, a team of the domain experts in the clinical space, the AI engineers, the informatic people, the data specialists, and sort of built that team and planted them smack in the center of the neurology department, clinical department. So you would already see this building of a team and this idea that that was critical, having these people that are translating all of these domains to really hit the fundamental problems at that time that we were addressing in neurology, neurological care. And then I think subsequent to that, recognizing that you needed a coherent data strategy. And this idea around AI, that it would really meet the quadruple aim in healthcare. Specifically, how is it going to impact either patient outcomes, healthcare outcomes, the patient? Number two, how AI could be used to improve or enhance the patient experience, the provider experience, the entire healthcare experience. Three, how are you leveraging AI to improve efficiencies and value, and how you could use AI to reduce costs in the healthcare space. Considering we spend about $4 trillion in the healthcare space in the economy, it's I think it's about a quarter of the government spending is on healthcare, and yet our healthcare, our life expectancy sits at 38th between Cuba and Lebanon. And here we're all excited about the power of data and the power of AI, but at the end of the day, we have a huge problem. Technology never solves all of it, but importantly, that was a key component. I would add one other key role that prepared me for here, and that was being part of the Clinical Translational Science Award as the PI. And these really focus heavily on community. They focus as a key point is how do you engage your community to address their needs in research in meaningful, authentic, bidirectional ways. So as the world transforms us around us with technology, the concept of the digital divide, digital literacy, digital access, all those things were really, I would learn so much in the year and a half prior to coming here from those experts, many of you are in this domain as well, and Craig in particular, that would help me understand that it's not just technology, it's just not healthcare, it's about the holistic approach. And so coming here, the first people, even before I took the job, I remember sending a note to Sharon Wood from one of my visits and she asked me who I want to meet with. And I just listed, I want to see Peter Stone in the robotics lab. I want to meet Adam Clivens in the AI lab. I want to meet, Alan Cole in the social, in the School of Social Work. And so I was sort of coming in with this sense that there was something really exceptional here. And I would add one last point. Mayo has such a tremendous applied environment, but I would always say we don't have the engineers. We don't have the computing capabilities. We don't have the analytic capabilities to the depths that we need to really mobilize and transform at a level that I think is possible here. But what we needed here is also an academic health center, and we had to build the presence where we could create those collisions and synergies to really have an impact. So that was a long answer, but I think hopefully we'll have a few more questions in our time allotted.
No,
so, sorry.
but important, and thank you for that. I know people who are familiar with your presence here and some of the things that you're trying to do via your leadership, but I think it's good for them to have a little bit of that sort of, Claudia before Dell Med, and so very important. So I know a few weeks ago you were at a Innovation Health Summit held by the president, Jim Breyer, who's a big-time venture capitalist here in Austin, a transplant from Silicon Valley. And part of what you delivered at that event was kind of giving the attendees a sense of what's happening at UT in terms of the AI environment, what's happening from a research perspective, what's happening in terms of how some of this work gets translated into practice. And I know just based on our conversation that as the smart leader that you are, you knew that it was important when you got here to begin to start sort of a listening tour, right? Mm-hmm. Trying to figure out, what's happening here, who are the players, and where is the action happening, just to give you a sense of not only who and what that is, but then also the direction that you might take that might be a complement to that. Could you share with us a bit about what you've learned about what's happening here at UT in terms of AI research, where you think we are strong, and in areas where you think there's opportunity for improvement?
So I think we heard a bit on the video sort of about some of the assets, but we are so strong in this area around not only computing. When you think of the Texas Advanced Computing Center, and one of the first things I would do in terms of as a dean of medical school is invest in actually co-investing with the other schools around GPUs and the need to have compute capabilities, because compute capabilities will be foundational to be able to really leverage some of the assets of the university. The other area, as I would go around, is understand the profound expertise in the analytic side, the computational analytic. When you look and meet and you hear from Karen Wilcox and the Odin Institute, or you talk to Adam Clivens and Alex Demakis and hear about this groundbreaking work they're doing, you'd really recognize the power of that capability. On the translate side, though, that is now going from models to actually applying them to medicine. This isn't unique to here at the university, but that AI chasm of a great model that then doesn't perform, I would also be looking for the places where people were beginning to translate. There are some great examples here. One example I'll give is, David Petafar, and he's a neurologist working in the intensive care unit often. And he would figure out how to take live data, synchronous time series data, and get it plugged into tech. And it sounds like a minor thing, but the reality is nobody's done that. Eric Topol, one of the leaders in AI, thought leaders in the country, when he's like, wait, they figured out how to do that? And like, yes. And why is that so important? Because the majority of information about you and us in the healthcare domain doesn't sit in your electronic record. It actually sits in the intensive care unit, or in the ambulance, or in your home, or in a sensor. And the fact that you can now get that data synchronously in and leverage the power of computation. Now he's using it to help determine little babies that are at risk of sepsis, but with the synchronous data in hand. Another group is also looking at how to predict clots in patients, little babies that get catheterized when they're having heart problems. And this risk of clotting is very difficult to detect, but having that real-time data, providing that real-time insights to doctors at the bedside is really the transformative stuff. So that has to be validated, but just examples like that where things that I would come across and would recognize that the phenotype of the people, the expertise, was tremendous. I would also comment on just on the social implication side of it. Meeting you, Craig, and hearing about the work you do and the thought leading, and Brene Brown had a reason she reached out to you. I have learned so much just in the short time hearing about your work and your commitment, the good systems work that's being done, Ken Fleischman and the work that he's looking around ethical AI. It goes on, but that synergy between the humanities, the human, the technology, there was just such a rich environment here for that. So I believe we're really poised to capitalize and leverage in a way that's going to have meaningful real-world impact, but it's not without recognizing that's a daunting task. It's not going to happen overnight, but we do have to figure out how to sort of point ourselves in some common directions to fill in the gaps so that that chasm from a great model, a great paper, a great grant turns into something that's going to impact our society, our patients, from a healthcare standpoint, our communities, with an eye toward not leaving people behind in the process.
Great. So I know, just based on conversations that we've had and conversations that we've had elsewhere and conversations that many of you have had, and it's been mentioned by David, mentioned by President Hartzell, you as well, the pace at which these changes are happening is quite remarkable. And in many of our conversations, right, with stakeholders, many of you in the room, that's oftentimes articulated. And a word that oftentimes comes up is scary or uncertainty about what this all means and what are the implications, right, for how these technologies are being sort of deployed in ways that we don't quite fully understand. One of the things that's become quite clear, right, are some of the issues around bias, some of the issues around disparate impacts in terms of how these models perform, when and where they perform best, whom they perform best for. I wanted to ask you to maybe share with us, as you think about that particular aspect and that particular challenge, some of the real limitations of these systems and how we deploy them in real world contexts like healthcare, for example. Are there particular things about the pace at which this is all moving, the implications for bias that are of particular concern to you? And what are your thoughts about what we might be able to do as a way to intervene, as a way to sort of mitigate some of these disparate impacts that are quite clear and visible in terms of the application of these systems?
Yeah, really important concept and a lot in there. I would say, first of all, it's also pace and as well as incentive. Sometimes it feels like the product has been produced before we've really determined, is it the right product, AI product, let's say, have we engaged the right stakeholders, is it valid, does it work, is it safe, is it free of bias? And so there's just so much out there. I mean, being bombarded by companies and everyone sort of getting into the mix of developing the latest and greatest, which on the one hand creates a really rich, innovative environment, but also feels overwhelming to wrap your head around it. I think the U.S. government recognizes that. In October of 2022, they had a blueprint for the Patient Bill of Rights, sort of recognizing right out the gate that you want to be sure that AI implementation would involve and it would be safe and effective, because it isn't always. A group would come out with a sepsis detector, which was going off right and left, beeping, and in fact, not only was it not detecting sepsis, it was delaying time to detect the sepsis altogether, and so patients were actually suffering and potentially at risk of dying. So AI isn't just a technology. I mean, it has serious risk. It has to be safe and effective. Number two, this point about algorithmic discrimination, is the model that you've generated, the algorithm, truly free of bias? And when the system has bias baked in, it's nearly an impossible thing to do. On the other hand, be able to challenge that bias and test against it. Recently, I think just very recently, Google AI came out with sort of a strategy to look at health equity and the performance of your model with what are called adversarial data sets, ways to test if it actually is free of some bias. And you can actually study that and see it. And I think we're moving forward in that space, but the pace is sort of coming ahead of some of this formal testing, so we're sort of playing catch up on that. I think a third part around the Bill of Rights is data privacy, that your data is being used in a way that's not abused and you're aware of it. And finally, as a patient, that you know that an AI is being used for you in some capacity, and that if you want to opt out, you can. So when you have this pace flying, and you've got patients trying to understand what's going on, let alone students and doctors and the workforce really not yet prepared to deal with it. We're, to some extent, I would consider myself still AI illiterate. We aren't training our doctors in that space. We're not retraining our workforce. So with all that happening, it's a super exciting time, but we have to be vigilant and mindful of the risks, and then be deliberate about our actions to address them.
Yeah, you raised a number of important points. So let me pick up on one, the training part. We know that the preparation of the future workforce in this space is really important. In my class, when I work with undergraduate students, we talk a lot about, and this is becoming something that's increasingly important to students, right? Will there be jobs for me when I graduate, right? What's happening with the pace of change? We're seeing a lot with generative AI. There's an interesting chart that I show in my class and in some of my talks that I give. And the chart is one that was very popular about maybe 10 years ago. And it's like with mountains, peaks, and valleys, and sort of at the lower levels in terms of AI performance and the kinds of tasks that AI can perform, things like language translation, things like IBM Watson. These were all things, right, that were considered within the realm of machine intelligence or computer intelligence. And at the higher levels, right, the sort of peak levels beyond the sort of capacity of machines were things like creating art or writing a book or providing sort of real-time feedback and things of this sort. These were things that not too long ago were considered sort of off limits, right? Or where we as humans sort of excelled as opposed to machines being able to excel. That gap has closed significantly. Mm-hmm. And so raising a lot of concerns about what skills can humans develop that won't be rendered obsolete by machines. Mm-hmm. And I've heard you in a couple of public presentations that you give, and I'm sort of paraphrasing here, so forgive me if I butcher it, but what I've heard you say on a couple of occasions is that artificial intelligence won't replace healthcare workers, but healthcare workers who don't use artificial intelligence will be replaced. And I'm wondering if you could elaborate a bit on that interesting sort of dynamic.
Yeah, no, it's important. And I'll qualify one part as the first part of the thing that you were teeing up, which is the ability for artificial intelligence to do a lot of things that we can do cognitively. I mean, it right now is passing, ChatGPT 4 can pass the USMLE Part 1 with about 85 to 90% correct. But what I can tell you is, first of all, that my best students, trainees, aren't necessarily the ones who've aced that test. It's not in and of itself a measure of the best doctor, the best healthcare worker. And then when we look at what historically in medical school training has been focused around sort of building the IQ side of it and the acumen, okay, that's being done pretty quickly on the side here. But the EQ side of it remains critical. So first is sort of doubling down on that side of what it is to provide care. And what does that look like from an EQ side? And beyond providing care, the patient's experience, how you empower them, how do you empower your community in that regard? When it comes now to the other point of being replaced by, as a doctor, if you don't learn your pharmacology or the side effects of your drugs, you can write all kinds of scripts, but at the end of the day, you need to know if your patient demonstrates some outcome. Was that the drug? Was it this? Was it that? So that critical thinking, you're aware of the biology, you learn the mechanics. Well, in the same way, you're going to have to learn what is going on with these AI algorithms in order to advocate for your patients, in order to understand when they start to degenerate and not perform well. Furthermore, they talk about the new stethoscope. It's not my phrase. I read it elsewhere, that the stethoscope of this age is data science. And so the ability to understand and work with data, when you've got a dashboard in front of you giving you inputs from multiple areas and you need to synthesize that on the spot along with the amplification of a tool like AI or generative AI to synthesize it for you, you've now created really a combination of human and machine together. And if we ever lose the human in the loop, and we don't even know what the loop is in AI, then how can we be the human in the loop? So behooves us, it's imperative that we not just lean in. I mean, we have an obligation to lean in, and I don't see AI replacing humans, but I feel they can amplify and assist and augment what happens in that situation.
Yeah, no, I think that's an important distinction to make, and one, unfortunately, that's not oftentimes made in these conversations. I know that for you in the medical school, community engagement is a really important facet of what you do, and how you serve the public. And looking at some of your work at the Mayo Clinic and different things that you were doing, things that you were standing up, had a very strong and impressive community sort of stakeholder engagement component. And I wonder if you could maybe talk a bit about, as you sort of project into the future, via your vision and leadership with Dell and what's happening over the next few years with the UT Health Center, how do you envision, right, stakeholder community engagement and what that might mean for how we move forward, for example, in the application of AI in the space of health?
Yeah, I think a couple points, and I think Dr. Shokar is right there, so she's our chair of population health at Dell Med, and I've learned a lot from talking to her and her expertise in this area as well. I think first of all is the recognition that we aren't creating tools just in isolation to just put upon our patients or our community, or let alone our doctors or our nurses. And so the stakeholder engagement throughout the pipeline of AI development isn't something that just comes on the back end when you want to kind of shove it into wherever you need to use it, but it's a fundamental principle of community-based participatory research, whatever that may be, but it's throughout the entire design. From the conception, is it the right thing, and how are you actually working with your stakeholders through the whole process, from design to model development to live testing to implementation, and then understanding that that could be changed or altered by the feedback you're receiving as opposed to just a product you might be selling. And so those principles, I believe, become so important today because it is overwhelming. Healthcare is already highly fragmented, and you can imagine just being bombarded by all kinds of things that are said to be the next latest and greatest. And so I think that a CVPR type mentality is sort of core to the discovery and the implementation. You and I've also learned from you that NIH and NSF, they want to know that you've actually engaged your stakeholders and community into the actual process of what you're developing. And we don't fully understand the barriers. We're just all surprised when we plug in some new product that says to be great and nobody uses it. I'm like, okay. Well, the reality is understanding this. We don't want a whole lot of products that nobody's going to use, or AI, so-called discoveries that are going to have this great impact. I will add, just at a fundamental level, a personal anecdote, an experience of just a simple app to look at cardiovascular health among African Americans. And this app was done in a CVPR approach, where from the beginning, you engaged the groups that you were working with in the community to help design the app. How you designed it mattered for how they're going to use it. You ultimately took through the whole path to implementation and could demonstrate through that life cycle that you could impact truly meaningful outcomes on glucose, on cholesterol, on behaviors, et cetera. And again, if we lose sight of engaging and creating the next AI-empowered app and don't have that step in there, I think we're going to just spend the next 10 years wondering why these things didn't get adopted. And right now, digital health and AI adoption is it's an industry that's very low compared to some of the other industries like finance or banking or these other areas. And that's because our onus is different. We are actually impacting health. We want to know that it's impacting outcomes, and we can't have a predetermined idea of what that looks like without that authentic engagement. So in terms of here, you and I and others have spoken about how do we do that in this community? We've got the analytics, we got the computation, but the gap is engaging the community, that translation from the model to implementation. So we really see a huge opportunity for creating an environment to really accelerate digital health technology adoption by engaging the stakeholders through the process, particularly also looking at that space from where you validate in different environments, different populations, different settings, because we believe that our ability to accelerate all this innovation rests on the ability to implement. So the need for implementation scientists, community-based participatory researchers, understanding your populations, is a key part of what I see the lifeline of AI here, and the opportunity to synergize with what I often say, like medicine comes to Odin, Odin comes to medicine. Well, let's take AI to the community and make sure the community is part of those solutions.
Absolutely, yeah, no, thank you for that. And if you have ideas in the room about how to facilitate, how to make that happen, be it your organizations, your research, your networks, ecosystem, please share those on the idea board as well as with each other as well. One more question, and then I think we'll open it up to have maybe a few minutes for Q&A. But before that, I just want to say thank you and your team at Dell Med for partnering with us on a new call for proposals that was just announced, I think, yesterday. The day before. So we are joined together to do some seed funding for UT researchers who are sort of designing and deploying AI to address and mitigate health disparities. And so if you're a researcher, please be out on the lookout, or please look out for that, and certainly feel free to contact us, and we look forward to proposals that you and others may submit. So my final question is, I want you to put on your sort of futurist hat.
Yeah, okay. Well, it's always on.
Yeah, so let's say we're in 2029, so that's 5 years from now. I feel like the way time flies, that'll be like next week. But where would you like to see Dell Med?
Oh, Dell Med, okay.
And the whole sort of thing that's happening around the UT Health Center, the new hospital that's on the horizon, MD Anderson that will be here as well. So there's a lot that's about to happen, and so you are right at the center of what will happen. And I'm wondering, could you share with us, as you think about this future, what are you envisioning? And 5 years from now, where do you hope we'll be?
So, I mean, building the buildings and hiring faculty and all those components are sort of part of you would hope to see be transpiring over the years. But more importantly is, do we build a culture, a continuous learning ecosystem, a collaborative environment where we continue to cross boundaries, to converge, where we can bring talent and knowledge together? Did we just stand up structures and hire a lot of people, and there wasn't this sense of this collective mission toward advancing and impacting healthcare and making sure these innovations we're developing have a meaningful benefit on the community? I think that would be, to some extent, failure would be that we could put all these pieces together, but we didn't deliver on the promise that we were going to make a difference in the community itself, and that's broadly defined. That would be one thing. So my hope is that we have these things coming together. We're hiring, we're building, we're getting this ecosystem pulled together. We're getting more connections with the university, more organic, and both at a grassroots level, but some real notable programs that we would do together, whether those are in institutes or centers or whatever we define them, that allow those collisions between the schools in a more structured way, because the collisions are great at the grassroots, but some very directed hiring to show that we could begin to bridge that chasm and work together side by side, because as I did at Mayo, bringing that whole team and plopping them in the center of the Department of Neurology outpatient area, I want to see that same thing where we're working side by side in this growing healthcare environment. And I would say that overall, to me, that's the main thing that's going to happen over the next years, and that ultimately the technologies we bring in are advancing and improving, as opposed to, kind of getting so seduced by what's possible that we don't do anything. So to me, there's a real sense of urgency to deliver. And then finally, that we could be, the University of Texas, the Dell Medical School, the other schools could be leaders in the training and preparation, not only of the students, undergraduate, graduate, but the healthcare workforce, and creating environments to make that happen. And so that's, again, going to require some really strategic thinking and tangible investments and accountability to deliver. But at the end of the day, I really see such opportunity, and I believe that in 5 years, it's not just talking about the opportunity. We're going to actually see concrete examples of it, and then it'll set the stage for the next phase of our opportunities here within the Academic Health Center and the university.
Thank you. So I think we have a mic around. We think we have maybe time for a couple of questions, if there's any questions in the room. Reactions, thoughts?
Overwhelmed everybody, huh? I have that effect sometimes.
So there are a couple, Bruce there, and then right over.
Well, first of all, I'm really pleased and honored to be here. And my question is, besides the main causes of mortality around the world, cardiovascular disease and cancer disease, and in your experience as a healthcare professional AI expert, is there any other disease you might to change, you might want to create more treatments, like as your professional and personal experience?
Well, I'm a neurologist, and as
yeah,
a result,
for example, in neuro, there are like many diseases, autoimmune diseases.
Yeah, I mean, of course, it's a broad question, but I think at the end of the day, one of the things about diseases, there's a lot of convergence places where you can drive innovations and discoveries that impact multiple diseases. So I'm always looking for those opportunities. So give an example. When you think about some of the advances in neural engineering and electrical stimulation and how the potential to impact not only Parkinson's disease with tremors, the potentially to increase the regenerative potential within the brain after you've resected a tumor, the ability to use that to treat pain, the ability to use that to address paralysis. So harnessing certain ways in which convergent science has a broader application across many diseases is where I tend to focus, only because looking for sort of, I guess, probably the maximal impact and bringing multiple minds around a particular problem. So in that regard, that's probably what I spent the first 3, 4, 5 continuing months understanding where all the brilliance was and figuring out if we, together with the deans, could identify a few key areas to focus, but realizing we can't solve all of it. I think the other part is to be aspirational. We talk about treating and managing disease, which is important, but we should be bolder in thinking about curing disease. Not that that's necessarily always possible, but that just lifts the bar up a bit and says, you know, we're committed to really finding those breakthroughs that are going to really have that type of meaningful, transformative impact.
So thank you.
I don't know. I can hear you, though.
Can you hear me okay?
Yeah.
Sorry. So this question may just be too hard to answer, but I'll throw it out there anyway. So the university is a little bit closed to our community, our outside external community, to the Austin community. How do we open up the doors and let people outside of the university know what's happening here? There's so much fantastic stuff that's happening here. How do we get companies like Emerson involved with what we're doing here? And as I say, it's a big, wide open question. I would love to see more community engagement. I know we have pockets of that happening on campus now, but how do we open up the doors even more to get more partnerships outside of the university to help us move forward more quickly?
Well, it's an interesting thing because I think one of the challenges is there's so many doors. And so the doors are being opened all over the place. But the problem is for the community, that's hard to know what door do I even go in. So when we talked a bit about creating, at least in the AI translational space, if you sort of describe a bit of a door and welcoming the community, knowing that here in this part, we're going to be focusing, let's say, on implementation of new technologies in digital health, that gives a door and it provides opportunities to engage around community advisory boards or community organizations. But I think it is challenging. And the other thing is, what's your narrative and who you're speaking to and being mindful of that audience and tailoring it. And I think maybe you could speak a bit more about this scenario about how we can really invite people in knowing that there's just hard enough for ourselves to figure out what's going on, let alone others.
Yeah, no, absolutely. I know it's something that we've talked about and things that you'll hear about later on today, throughout the day, just different strategies that we are participating in to make those kinds of invitations, to open up, recognizing that we, and when I say we, those of us here at the university, certainly have much to offer to the community and beyond, but realizing, right, that the community and beyond have so much to offer us as well. And so there's so much to benefit from having that kind of engagement, making those kinds of invitations possible. And it's something, as I mentioned in some of my earlier remarks, that IC Squared is very committed to. And one of the things that I found really invigorating about IC Squared is our commitment to that sort of outside sort of stakeholder engagement and how those conversations, and I was being quite genuine, those conversations make the things that we do possible, allows us to sort of bring this kind of community of people together. And so we are committed to continuing doing that in a variety of ways, workshops, advisory boards, really just trying to figure out creative ways to get additional input from stakeholders in ways that we think will enhance what we try to do and therefore deliver on our promise that what starts here changes the world.
We have time for one more.
Okay.
Can you hear me? Oh, yeah, no, you can. I'm over here.
Oh, sorry.
I'm Jim Colson. I'm the VP of Digital Health at Texas A&M. This is amazing. I have a long history in industry, actually. I was an IBM fellow, worked on AI and machine learning, and worked on Watson. You talked about that. And my question is, I've only been in the healthcare space now for a few years after retiring from IBM as a fellow. the thing that I see in healthcare that doesn't resonate yet with me about industry and the evolution of technology in industry is that the consumer-supplier relationship, which you would call the patient and provider relationship here, the consumer-supplier relationship, the consumers pay. And so there's a demand, there's you know, a capitalism world that lives there in terms of that. And here, in the healthcare space, the consumer doesn't pay. They're set by the stakeholders that are payers and set regulation and policy. And so as we're doing innovative work around digital health and machine learning and AI, generative AI in particular, how do you see that third party participating in this work and driving the evolution forward? That's my question.
So you mean the payer?
The payer.
Yeah, well, it's got a long way to go, and just trying to even figure out what's the unit of pay. You develop an EKG algorithm, AI enabled, and now you want put out in practice. You've got IP around it, and are you paying for the IP? Are you paying for each time it's used? Is the hospital paying a fee? All that is to be determined. In fact, I think it might be old data, but as of a year ago, there were only 2 FDA-approved AI-enabled things that CMS, the Center for Medicaid Services, had actually approved to pay for. Which is why it'll be an interesting environment of that translation of all the investments translating into the bottom line. I think it's when you start showing, though, an impact on outcomes. Like, you can demonstrate that it improved value, improved outcomes, reduced costs, et cetera. If an insurance company knows that this is going to actually be less costly, well then, and you're the ones implementing it, and you've got data to support it, and it's been rolled out in many different environments to prove it, I think that's when the payers come. But you're right, there is this tension between the two, and that's probably also contributing to the slowing in adoption.
Okay. So I think we're
What was that? Oh, I'm maroon too, sorry.
Okay. We'll forgive you. So I think we're getting the signal to cut. Claudia, I want to say thank you so much for being here today. I know you have an unforgiving schedule, and so we don't take for granted your presence here today. So thank you. David as well, thank you.
Thank you.
And thank you for your vision and your leadership. We're really excited to see what you bring to this campus, what you bring to Austin, the state, and beyond. And so thank you so much.
Thank you. Yeah. Thanks for the opportunity.